My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
All right, and welcome back to the Fix Podcast. We are on with a very esteemed guest today. So as you guys know, we always reach out to our audience to hear about different things that people are interested in, things that we could canvas a little bit better. And, you know, one thing that Soren and I can talk about for days is hard tissue. And we can talk about how to do, placing implants in a native bone, doing remote anchorage, all these different things that are, it's sort of the more common things that we think about with full arch, but some of the things that we kind of gloss over a lot, partially due to our own naivete, is soft tissue stuff and PRF and other regenerative materials and different methods that we have out there. Even though we do actually utilize some of these things in our clinics, we don't always feel that we have the type of expertise necessary to really talk about it. And so a name that just kept coming up for us was Dr. Rick Miron, who is a huge innovator, pioneer in the world of PRF and its various applications in medicine and dentistry. And it's really transformed what we're able to do with, a patient's own blood and their own body, and how that can help us out with different regenerative techniques that are good adjunct to full arch treatment and all kinds of other kinds of things that, we're aware of and also not aware of. So I'm super excited to welcome Dr. Rick Miron onto the show. Thank you so much for coming on, and I'm really looking forward to this one.
Absolutely, as am I, and thank you guys for the invitation.
Yeah, no, absolutely. So, I mean, this is a subject that, I've definitely, I've got a few, friends that are just absolute PRF nerds. And when I, had first reached out to you and you were gracious enough to come onto the show, I reached out to Dr. Sean Land, a really good, close friend of mine, really, really into regenerative dentistry. And I think he actually went to one of your courses at one time. But he is a huge, huge fan, and he helped us out with putting together some questions and things like that. And I just know he's spoken so highly of you, and it's just so great to have you on. So we did put together a few things, but I was hoping that just for the folks at home, if you wouldn't mind just kind of canvassing a little bit about you, where you're coming from, your education. I tried to read off your biography before you came on here, and there were so many awards that I felt it would come a lot better, out of your mouth than mine.
Yeah. It's kind of a different story to tell because I'm not a normal dentist by any means. And most people know me for the research that we do. And I like to start from the very beginning. Sure. I grew up in a very, very small city in North Bay, Ontario. And it's about 400 kilometers north of Toronto. So it's way up in the north. There's not a lot to do there. And when I got to high school, our science teacher was actually an ex-dropout of a University of Toronto in the science department. And he got so frustrated with academics that he decided that he was going to go teach high school back in his hometown of North Bay. So when I was 13, my science teacher was a university professor who had written hundreds of papers. And now he was going to start teaching us, basic grade 9 science. And what he did with the top students, I mean, it's a crazy story now that I look back on it, but what he did with the top students is he had us enrolled in some science fair projects. And so in the summer months, he would hire us to do these different research projects. And I was basically doing like his continued university type research at 13, 14 years old for 2 months every summer, where I had these jobs in the lab. And that's a huge leg up. So we're now competing at these national science fairs in Canada. Our school's winning first place in every single division you can imagine. And I'm getting to travel around doing conference talks at these science fairs. I'm now doing, by the time I'm 17, international conferences and competitions in Sweden and Switzerland, and I did some in Chicago. And so by the time I got to 18 years old and I was going to apply for university, of course, I had decent grades, but I had all these extra accolades. I won academic scholarships, full ride to wherever I wanted to go. Awesome. And in university, as you guys probably remember, in undergrad, you try and get the science research job if you want to go to medicine or dentistry, right? It was very common during our summer months. We try and do little projects. So, of course, I had already published like peer-reviewed articles at 18 years old with my high school teacher. And so I got every summer job that I wanted, direct pass to go to dentistry. Yeah. And so, looking back, I didn't realize how special it was and how lucky I was. But because I was doing this, I just had a knack for science. I was always doing it. When I finished dental school, which is what I always wanted to do, was be a dentist. When I finished, I pursued also at the same time a master's in cell biology. I was very interested in dental implants. So I was doing actually research projects where we were taking Straumann implants and we were coding, this is back in 2006, trying to figure a way to get growth factors on a surface of a dental implant. So I was doing work with PDGF, BMP2, enamel matrix proteins, etc. I had published a couple of good articles there, and in 2009, I won a full scholarship, and this is very unique for Canada. But the Canadian government, they give a full ride for you to go anywhere you want in the world, and they pay for everything.
Wow.
So for 5 years, they'll pay for all my tuition fees. They'll pay for all my living expenses, all my conference fees. Only 5 people get this award every
Wow.
year, and I won one of them. So I'm like a green ticket now, and I'm like I can go to any school. They don't have to pay me anything, and I'll be a PhD. And I did a PhD in molecular and cell biology. Well, I went to all these different schools, and I was trying to decide where I was going to spend the next 5 years of my life. I went to Harvard, I went to Michigan, I went to Germany, Switzerland, Italy, and when I went to Bern, Switzerland, and that's the school that's most affiliated with Strowman, I was like, man, this is the place.
That made sense.
That's where Danny Boozer was. That's where Tony Scully and Klaus Lang, a lot of big legends in the space. And they are 30 minutes away from Strowman headquarters and 45 minutes away from Nobel Biocare headquarters. And so these huge, massive companies want to collaborate locally. Yeah. And so I stayed there for 7 years. I pursued perio as well as a PhD in molecular and cell biology. And my life was just literally living in the lab most days and then spending 1 or 2 days a week in the clinic doing perio work. We developed a lot of biomaterials along the way. And then I moved back to North America in 2016, located in Florida, and then I set up a research lab. And our job is literally try to get materials FDA cleared as fast as possible and bring new technologies to dentists.
Wow.
So, that's a little bit of who I am. It's hard to put together in a few sentences.
Yeah, it's amazing that's the abridged version.
Yeah. I obviously am very passionate for what I do, and for people that take my courses, they understand. Like I put a lot of time and energy into really making sure that we're doing things that are well done. And what people forget is like if you guys are using dental implants and biomaterials and membranes and this and that, like those materials before they were ever launched to market and you guys ever got a chance to use them, 4 years before that, we started preclinical research to get FDA clearance. Right. So like right now, I'm literally testing Strowman implants that are going to be launched to market in 2029. Yeah. And a guy like me has to take, cells and seed them on the implants and make sure that cells behave properly on the implant surfaces. And that'll take about a year to do. And then we'll do the first animal study in 2026. And that is usually a large animal model. So it's got to be a dog, it's got to be a mini pig or a monkey. And those are huge projects. They take a year and a half to complete. And when we finish that, then the FDA says, okay, you guys get a check mark. You can now go to the next step and do the very first human study. And then it'll be 2027. We do the first ever study with these new Strowman implants. And then after doing a randomized clinical study, then finally they get FDA cleared. So in my office, 95% of the things that I do is it's not materials that you guys have access to. It's not things that are FDA cleared, right? It's all kind of where the future of dentistry is going. Wow. And so I get to live in this world where we need to have obviously special IRB permission, which means the universities have to approve, say this is ethical. They've done the preclinical work. And then, all these new toys and new tools, we bring to market. So our team's pretty excited about being able to do these projects.
That's an amazing story. Very cool that you have access to that, and really, really cool that you're walking around and so much more about the industry, even than we do, right? Because you're 4 years ahead of a lot of people. What would be that transition? You talked a lot about kind of the stepwise that you've taken to get to where you're at in the career now. I'd love to hear a little bit about where PRF, PRP kind of fit into that, and what you're doing as far as your courses and how it evolved into that.
Yeah, I think even dating back to before the courses were started. So in 2011, we understood, and I was in Switzerland from 2009 to 16, this PRF world was going to be a big thing. And so we started to do research projects because there was not a lot of like very good work out there. How do you spin your protocols? What's RPM versus G-force? how much time do you spend, what kind of tubes do you use? All this stuff was back then was nobody knew anything, right? So we decided that we were going to start pursuing this, knowing that maybe in the future it would probably be a big field. And so as we were publishing more and more work, and really I think the year 2015, 2016, 17, around those years, we had published a series of, many different articles. It was becoming more and more popular to the point where we started doing courses on the technology, and so that's how it basically started. And honestly, I love obviously teaching as well. It's a lot of fun for me. But back then, a lot of people don't realize like how low and how small the academic salaries are for
Yeah.
people
Right.
like me. And so, I had graduated. So imagine I had an undergrad completed in BMSC. I had done my dental degree. I had a master's in cell biology, a PhD in molecular and cell biology, and a
It's a
perio
lot of
degree.
letters.
Okay. And before I could do my perio degree, I had to redo dentistry or medicine. So I actually studied medicine in Switzerland
Wow.
as well. Okay. So I did 19 years university.
Wow.
And when I moved when I moved from Switzerland back to US, and I wanted to be in Florida because growing up in Canada, a lot of people move and retire to Florida. So my parents actually live in Florida now, as does my brother. And, I sat with the dean. I said, I really want to live here. This is my school. I know at Nova Southeast University, it wasn't like a highly reputable school, right? It's not like the Harvards or Michigan, but I was like, I really don't care. My lab will have the reputation it needs to attract people to courses and publish good data. She sat me down and she's like, Dr. Miron, I'm looking at your CV here. You're a dentist from Canada. That degree doesn't count here. And you did it in the French speaking part. So you can't even apply for you can't even write the boards. You're going to have to redo 2 years. Your perio degree is not valid here. You did it in Switzerland. It's top school in the world, but you're not a periodontist. You're not a dentist. You're a PhD, and you spent your entire life in school. You have 1 year experience of real professional life. All your years were spent in university, and you're a 1 year postdoc, and your starting salary is going to be $50,000.
just
Oh man.
reduced all of that to $50,000 a year on the
Yeah,
on the subject of really just provenance of all these things, and they just wouldn't recognize it. That's Florida in a
yeah.
nutshell.
So I had obviously done a lot of years of university, and I had to pay back some student loans and stuff. And I was like, I can hardly even live off this. I mean,
Oh yeah,
it's
it's a joke.
borderline
Yeah,
impossible. But with the dean, I was able to redo my dental training and get my license to Florida. So I was like, as long as I can do that on the side, we're good to go. Because when I can start working in practice, I'm like, I'll be fine, even if I just work, a day or two a week. So a lot of people in academics, it's just not very profitable. And very few of us have the opportunity to actually have done good enough research to be able to attract dentists like
right.
yourselves, let's say, to a course and be like, I took Dr. Miron's PRF course. It immensely benefited me. I now do PRF in my practice. Like, these people are very few and far
Wow.
between. So,
Yeah.
um,
Well, I certainly
yeah,
appreciate you for, sticking it out through all that time to get as educated as you did
yeah,
and to have had as little reward. I
yeah,
mean, to actually be recognized there at Nova when you first started and everything. I mean, that's just, it takes quite a bit of perseverance and dedication to what you were passionate about. And you've certainly benefited, the whole field of dentistry and beyond for that, passion. So that definitely, I appreciate you delaying gratification for so long. That's pretty cool. That's really
yeah,
cool. Yeah.
Yeah, we
yeah. I always say, in the research world, I think the biggest mistake that happens in the United States, and this was a little bit, and you guys can really pitch in and give me your feedback, but when I went from Canada or North America to United
Mm,
States to Switzerland, there was a big difference in the way research was performed. And I want your opinion on this because I have a very, very different background. There are so many researchers that in all the dental schools in the United States, they're not actually
right.
clinicians, right? When you think of the dental schools, you're either a clinical person and you're doing like no research or minimal research, or you're a researcher and you're a PhD and you don't know what it's like to work in a private practice or how difficult that is or what it's like to treat patients. So all these people are doing this research on MAP kinase pathways and osteoclast this,
Yeah.
and it's got very little clinical relevance. And when I went to Bern, Switzerland, Danny Boozer sat me down. He's like, Rick, you are no longer going to do research like that. you are going to do research that's going to benefit patient care in 3 to 4 years. Otherwise, there's no point in doing that. And so when I got back here, I was shocked because I think I'm one of the only people that I've ever met that is like a real researcher, right? I'm not talking a guy that has 15, 20 papers. I'm talking people that have hundreds of publications, et cetera, but also works in a clinical practice. They're few and far between. And if you don't work in a clinical practice, you have no idea how to ask the right research questions. Like now I started to ask, like, how do I actually spin blood to get more platelets in the cells? I'm a cell biologist. Let's figure out a way to get more platelets in this upper PRF layer so that we can go help, all of our colleagues when they're trying to treat their patients. Right.
Yeah.
So,
I haven't seen it personally. Right. Like I see a lot of dentists that, they hear about the newest research, right? They hear like in the fixed world that 4 implants work. You can load a prosthetic on 4 implants, and then they go and they just do it. But there's not a lot of people here, that at least that I know, in the close proximity with us. And we talk with a lot of top implant dentists, and not a single one of them is doing research. Right? They're profiting off of the research that's been done, and gracious enough to you, right, that you spent all this time to develop these concepts like PRF and stuff to benefit clinicians and the patients that are getting the treatment done. But you're totally right. In the United States, I feel like it's far and few between of people who are actually doing the research and then applying it on a day-to-day basis.
Yeah, and I think that's a little bit of a drawback in this country. But it's not the fault, right? It's not the fault of anybody. It's that when you graduate, like there's no let's go, spend $30,000, make $30,000 a year, and we'll go do a postdoc and learn how to do research and this and that. Like, you just can't afford to do that. The debts are too big, and you got to go and
that was going to be my response, is that you can't come. I mean, when I came out of dental school, right, and I was on the higher end, it was, I think I came out of school with like 360 to 400,000 in student loans, and now there's people graduating NYU, if you're including the living costs, that are $7 million, and 7 figures in debt, over $1 million in debt, and it's like they just don't have the means to take a pay cut to do research and stuff. They have to practice clinically, otherwise
that's how they're going to
survive. Pay for the loans that they got.
I mean, there's definitely a lack of financial incentives to go into the academic world and contribute to that greater body. And I definitely appreciate too that, in Switzerland, there was this approach of you're going to be a hybridized doctor because you are directly thinking about what are the clinical applications of what I'm doing, not being so mired into cell pathways, et cetera. Whereas, here in America, it's totally polarized. I mean, you're either clinical and that's your world, and you will go into PubMed just to kind of support an argument you're having with someone on Facebook, or you live in that research world, and there's not really much of a world in between to actually bridge that gap. And so on one side, you have people who are clinically applying things that have been researched 10, 15 years ago, and then you have people that are researching things that aren't going to come about for another 10, 15 years. And there's nobody that is really living between those worlds because the financial incentives just, it doesn't really make a whole lot of sense. There's not a whole lot of marriage between the two. And I think that stifles innovation.
And I think also because of the debt as well, and just the way that things go now, like if I was to ask you guys a question, name 5 of your top favorite implantologists that have more than 50 papers.
I would. Yeah.
Give me just a moment to pull up ChatGPT for a second.
Yeah.
Yeah.
In the US, right? So it's difficult to find, right? But like the reason why, a Dr. Michael Picos has been so well recognized in implant dentistry is because when he was my age, right, he was actually publishing papers, as was Craig Mish and those guys. So that generation did a little bit more. I don't feel like it's possible today for a young person graduating with the debts that just says like, oh, I'm really excited to play with BMP2. I'm going to go write a research paper on it and design the study and get an IRB approval and spend all this time making literally $0 because you're interested to find out if BMP2 works or not, right? It's very, very challenging, and you won't find those people. But I can go into Bern University and I could probably count 20 people that are superstar clinicians that all have over 100 papers easily in one university. right? So that's a big difference to be in that environment and living there like that for
Yeah, and we wonder
7
why
years.
so
And then,
much
yeah.
innovation is coming out of that small country and not from us. So, yeah.
Yeah.
Mhm.
And then you come out of it
Yeah.
and you come here and they're like, "Oh yeah, well, you still don't get a license."
Clearly don't value anything
Yeah.
you did elsewhere.
Ugh. Um,
Oh,
well,
man.
Rick, that's an amazing story. I really appreciate you going into depth about your background, your accolades, and I would love to kind of get into talking about PRP, PRF. And I think a good place to start there is there's probably a lot of people here that just don't really understand what it is in general. So it'd be great if you could just start with the basics. What PRP is, why it's beneficial, what are the uses for it, how do we transition into PRF? Why is that beneficial? What are the uses for it? And how can clinicians use this in their everyday life? And then maybe talk a little bit about where they would get that information, like things like your course, right? That they would be able to apply that.
Yeah. So even when I do education courses to doctors or patients, I try and simplify things as much as possible so it's easy to digest and understand. We have an amazing intrinsic ability to heal ourselves, right? Like you and I always give the same examples. We can be in the kitchen and we're sitting there cutting cucumbers, and all of a sudden, you cut your finger, let's say. It's pretty amazing to think you're actually
Yeah.
going to heal all by yourself, right? You don't need these growth factors and this and that to heal. Your body has an innate ability to heal itself. And how does that happen? Well, you have blood circulating, and the main proteins are fibrinogen and thrombin. And when that gets exposed to air and oxygen, a clot will form. And then cells get trapped in the clot, growth factors get trapped in the clot, and then over the next 21 or so days, you're going to heal. But it all relies on the blood flow to these areas. And the unfortunate thing is, as we age, our blood flow is continuing to go down, right? And our blood vessels are getting smaller. And I always say this in our facial aesthetics courses, like the reason why females, they have these cute chubby cheeks when they're young and everything's nice and elevated. And what happens as they age? You don't pump enough blood flow into the area anymore. You can't maintain that fat tissue. This starts breaking down. This will fall. Then you start having deep nasolabial folds, marionette lines, so on and so forth. And really, when blood flow is really reduced, and as you age, like I said, what happens to your beats per minute, right? You have 220 beats per minute when you're an athlete and 20 years old, and it goes down by 10 every decade. And by the time you're 70, your max heart rate is like 150, 140. And it's very
Yes.
bad for diabetics. Where do
Extreme is.
diabetics typically have problems? That's right. Furthest place away from your heart. So you or I always give the same examples. We could be playing tennis and get blisters on our feet. No problem. We heal up just fine. A diabetic person, they're not going to heal, and that can become an ulcer. They may not even know that they have this like defect that's this size and this thick
Yeah.
because they don't bleed. There's no blood there. And if they get infected,
Forget it. Yeah.
that's amputation. And so Bob Marks, who's the inventor, professor at in Miami, Jackson Hospital, who's retired now, um, he came up with the concept, and he said, "You know what? I know that those patients with these diabetes, and I know these ONJ cases, there's no blood flow here. And so all I'm going to do is I'm just going to take a few tubes of blood from the hospital. I'm just going to drop the blood
Mm-hmm.
and bring the blood to the area. Okay.
Just
So
bathe it.
inject it around the periphery of the
Yeah.
defect, splash some blood on the surface, and just bathe it in blood and bring the cells there because the body can't do it. And sure enough, the patient started to heal. And then he thought, let's put this in a centrifuge. I know what cells go where. Light cells go to the top, heavy cells go to the bottom. And now in a 10 ml tube, you can super concentrate 1 cc with all of the platelets. So you have like a tenfold increase in these platelets. And when they took that and they started to inject that around the peripheries and use it in ONJ cases and grafting cases, etc., they realized that healing was happening a lot faster, and that's when they called the technology platelet rich plasma PRP. Okay, so then it's used in many fields of medicine. I always say we use it a lot in dentistry. Dentists invented this technology, so we've been ahead of the curve forever since it started. And but the two areas that really made this technology boom was first being sports medicine. Right, you've got your $20 million a year quarterback for the Miami Dolphins. He gets a meniscus tear. He's told he's going to be out for 6 to 7 months. Why are you out? Why does it take so long for people to heal their knees and their Achilles, etc.? Answer: low blood flow. It's not like your cartilage and your knees are just filled in with running blood at all times. So it takes a really long time to heal. So they said, well, you got a blood flow problem. We have a blood flow solution. Let's take the PRP, inject it in this pro athlete's knee, and then healing started to happen. And then that went on the news. You had your $20 million a year athlete back on the playing field in 3 or 4 months. Everybody's like, what the hell did you do? And he's saying, I did this all natural PRP stuff. So now everybody's starting to know what PRP is. And the second area, which made it even more popular, was facial aesthetics. They started to realize that, hey, back then they were doing these microneedling treatments with vitamin C and hyaluronic acid. And one doctor one day said, why don't I use this PRP stuff? I'll put it on the face and then microneedle it in. So it's almost like getting a tattoo. When you put tattoo and the ink under the skin, it stays there forever. So they said, instead of putting a tattoo with ink, let's do the same procedure, but let's put some PRP in there. And that worked incredibly well. And then he called the technique, he called the technique vampire facial, which is one of the top 5 trademarks in terms of value in all of medicine, okay, which is just unbelievable. And then celebrities wanted to do more and more of these treatments. And then there was one celebrity in particular that went online and posted, I've done microneedling with PRP.
Yeah, I was gonna say
Her name was
that.
Kim Kardashian. She posted that yeah. And she made it super popular. One post online. Now I always joke around. I say every female over the age of 2 years old now wants, this vampire facial. And so very, very popular. Now, last question. What is the difference between PRF and PRP? Because we get asked this question all the time. When you fill that tube up in a hospital like Bob Marks did years ago, you always see, what does the phlebotomist do? They take the tube of blood and they do this, right? What are they doing? They cannot put blood in a regular tube with no anticoagulants inside because it'll clot in 2 or 3 minutes. So there's no way you could take that tube and send it to a blood lab and say, hey, go measure my vitamin D levels and blood cell counts, etc. Not possible. So they have to put the anti-clotting factors in the tube and then do this. So when you take that, and that's PRP, and you spin it down and you draw that up and you inject your pro athlete's knee, yes, you get all the benefits, the growth factors. We know it helps with healing. But scientists, clinical scientists have known right from the beginning, there's a little bit of negativity here. Why? Because
you need
you're
the
putting an
clot in the first
anti-clotting
place to
factor
initiate the healing.
inside. Right. Like the cucumber example, right? When you cut yourself, what is the single first most important
Form the
step to
clot,
healing? A clot needs to form. If you don't clot, you will never heal. Okay, so that's an extremely important step to healing. And so what was done? There was a modification of the tubes and the tube surface. And what they've done is they've made these tubes more hydrophobic, which is water repelling. So just like a dental implant surface that's, you guys have heard surely of SLA active and Nobel active, right? Hydrophilic surfaces. The more water loving it is, the more blood gets drawn to the surface, the faster it's going to clot, degranulate the platelets, and faster osseointegration. Okay. The opposite is true. If you don't want something to clot, you make the tube balls very hydrophobic. Okay, no chemicals. Now you can put PRF in that tube and it'll stay liquid for up to 4 hours. So now we'll do the same spin cycles like we do in PRP if we want to. Instead of using the chemicals, we're using a hydrophobic tube surface. I can do everything in under 4 hours easily. I can drop the platelet rich layer, and now I inject it in my pro athlete's knee. And just like PRP, I get all the benefits, the cells with growth factors, but I also get a clot to form. And clotting is the single first most important step to healing. So there have been thousands of papers that have compared PRP to PRF, and every study so far has shown that PRF is better
So
than
my
PRP.
follow-up to that then,
that's
are
kind of
there
a
still
breakdown on that.
indications for PRP over PRF in any of these types of modalities, or is it just altogether superior? I see. Okay.
Yeah, altogether superior. Yeah, every field. In fact, you'll still see a lot of people that will use PRP, and the 2 more common places is facial aesthetics and sports medicine. So you'll still see, orthopedic surgeons using PRP. The reason why is the PRF, it's hard to get into these markets because the companies that have been established and around for a very long time selling PRP, they don't want to switch to PRF. And the reason why is most PRP kits are like 100 and 120 bucks. The PRF tubes are $1 each. And so they're still making a huge amount of money selling these PRP kits to their doctors. And so they never get really introduced to PRF.
Wow. Can you talk a little bit about, because I'd love first, this is more of like a personal thing. I'm curious on facial applications for dentists for facial cosmetics with PRF. And then I'd love for you to go into where dentists can use PRF in their surgical applications clinically.
Okay. I'll answer the dental question first, and then we'll talk about how we got into facial aesthetics. So in dentistry, we know today that PRF is better for soft tissue than for bone. Okay. It helps with soft tissue, but of course, it'll still help with bone, and it greatly enhances the quality of handling. Because when you make sticky bone, your particles are all kind of together. It just makes your life a lot easier. So common places, extraction sites, just making sticky bone for your extraction site and even using it for soft tissue over top of it. We use it all the time for soft tissue around dental implants, any GBR procedures we do, sinus grafting, and then, of course, recession coverage. You can use it as well under certain indications. So really, there's a lot of applications for it. And I wrote an entire 400-page textbook, Understanding Platelet Rich Fibrin, which goes over all the data and, really the highest evidence meta-analysis of these systematic reviews of randomized clinical studies. So there's been, hundreds, thousands of papers that have been published on this. And so really there's a lot of applications. But when people start, I just say extractions, third molars, around implants, soft tissues, those are common places to start. And, as you get more advanced in your surgery, like Dr. Picos, who I teach quite closely with, he always says in his sinus grafting course, like, I have not done a sinus grafting case without PRF in like over a decade. He's just like, it just makes your life so much easier. It helps with the vascularization in this relatively low blood flow area, because when you go to a sinus on an x-ray, it's literally just a big black hole with no blood flow. And that's why it takes so long. You got to wait 6 to 8 months. We don't have blood flow there. So, by adding in these blood flow
and
growth
that's specific
factors,
to
that's where you
like
can help.
making the sticky bone
help.
itself, or is that like a membrane application, or what is that specific for sinus lifts? Okay.
Yeah, it's really the sticky bone. You can't use it as a barrier membrane, as you guys know, because it doesn't last long enough until the extended PRF was created. We can talk about that a little bit later. But that's how it's being utilized primarily in dentistry. The facial application, I can share the story if we have the time of how I got into it. It's kind of a crazy story, but when I was working, going back to my story, right? 2016, I moved here. 2018, I finally get the ability to work as a dentist, right? So in 2018, I start as an associate, and all I'm going to do is these perio and implant cases out of a pretty busy practice. The guy's name's Michael Canner. Dr. Canner is located in Florida, and he's like the dentist of a dentist of a dentist, and in his 60s now, and he's got this nice big practice with 16 ops, 3 associates, and I'm going to get fed basically all the perio cases 1 or 2 days a week that I work there. I start doing that over a small amount of time. And at the same time, when I'm teaching PRF to dentists, about 20% of the people are asking myself, and my brother actually created PRF EDU. So he and I work very closely together, obviously. And he's getting asked all the time, do you teach PRF and facial aesthetics? And I'm like, dude, no, like I'm a hardcore biologist.
Get out
and
of
I
here.
love implants. Like, get away from me, right? So yeah, that's how it started. But we just kept getting asked over and over and over again. And then one day I had this really nice lady fly from Greece all the way to Miami to take a 1-day PRF course as a plastic surgeon. And what was she doing in Athens? She was doing a hair transplant and a fellowship there. And she's sitting in the front row, and I'm like, what the hell are you doing here? Like, are you lost? What's going on? And she's like, no, Dr. Miron, I've been teaching PRP courses for 14 years to plastic surgeons. We're doing research right now and trying to regrow hair with this stuff. And I read your paper, Injectable Platelet Rich Fibrin, which was published in 2016. That was the first time that we started realizing we could use a liquid version. And I published the first paper with Dr. Joseph Chakroun in 2016 called Injectable Platelet Rich Fibrin Opportunities in Regenerative Dentistry. So she saw the paper. She's like, I don't care about all this dental stuff you guys are talking about, but when you explain it in the paper, not using the anti-clotting factors and the anticoagulants, etc., that makes so much sense to me. So I'm here, and we had done some data of like where do the cells go, etc., and what concentrations. She's like, I was wondering if after the course you can sit down with me. I want you to help me develop protocols for injecting in the face, where to inject and how.
Right.
And I was like, I can tell you the protocols. I have no idea how to inject. She's like, I told her, she's like, all right, if I tell you I need 6 milliliters of platelet concentrates with 1 million platelets per cc, can you help me figure that out? I was like, absolutely. I have all the data. We sat through it. We said, okay, Kathy, if you spin exactly at this protocol and grab exactly this layer from these 3 tubes, you'll grab 2 cc's each. You'll get exactly what you need. Okay. She went back to Greece. Now she's ordering 600 PRF tubes a month.
Yeah.
Jeez.
A month. Okay. So we're like, what the hell is this person doing? Right. So one day my brother says to me, he's like, let's just call Dr. Davies. We're like, she's like 6 months into this. She's ordered something like 3,000 tubes. I'm like, this must be
There's a
working
lot of bald
extremely
people in
well
Athens.
because she wouldn't be ordering this much. So yeah. She says it's unbelievable.
Wow.
I think it's working probably 3 times better than PRP is what our early research is showing. Yeah, we love it. I'm doing all my Instagram people, is what she calls them all the time. They're Instagrammers, the people that want to look better, posting these stupid photos online. But she's like, there's tons of them there. They love this stuff. And I was like, oh, okay, cool. I was like, Dr. Davies, I'm getting asked to do a lot of these PRF courses in facial aesthetics. Would you be interested in doing a 2-day program with me where I'll teach the science of platelet concentrates, you teach how to do the injections, then we'll do a hands-on? I think it would be quite popular, but most of our audience is going to be dentists. Is that okay with you? She's like, absolutely, Dr. Miron. I'd love to be affiliated with your research group. I have all the respect in the world for you. I'd love to do it. So I said, okay, great. My brother sends out an email to everybody that I had trained, and we capped it at 32 people. We sold out the course in 4 hours, one email blast.
All right, Taylor Swift.
So I was like, okay. So we do the course. Yes, we do the course, and it went extremely well, and it was a lot of fun. People really like doing the microneedling and practicing on each other, etc. It's all safe. It's all
You're not
natural.
going to attack yourself.
Think of how safe this is. You can't be allergic to your own blood. You can't have a foreign body reaction. You can't cause a vascular occlusion. Like, you can't do any damage really. And so it was a huge success. But then the difference is that these dentists that had taken this course here versus my other courses, they were calling my brother and saying, I started doing these vampire facial type treatments in my office, and a couple of these PRF injections were exactly as was recommended. You charge $700 to do the treatment, microneedling with PRF, which, by the way, can be delegated entirely to a dental assistant, so they can legally do that. You don't even have to do anything, and it's $700. When we add the PRF injections, we charge $1,100. But you tell Dr. Miron, these cases don't even cost us $50. We don't even have to do most of the procedure. My dental assistant does all the blood draw. My dental assistant does all the spinning. My dental assistant does all the microneedling. I go in for 2 minutes, inject a few places. I made $1,100. And these people, just like Botox, they're coming back every 4 to 6 months to do another treatment. And they're spending like $3,000 a year doing these treatments every year. It's like doing dental hygiene, but this is skin hygiene, and it's extremely profitable. And you tell Dr. Miron that since I took that course, I made an extra $200,000-$300,000 this year doing this. It's been one of the biggest money makers for my practice. So I'm like, holy shit! Nobody ever says, hey, I started doing PRF in dentistry, and
That's nuts.
all of a sudden I'm making an extra $200,000. Dr. Canner, the owner, he's had a lot of people do Botox in his office and fillers come and go over the years as associates. So he knows that people want to do it. But then when that one doctor left, we didn't have another doctor doing Botox. So one day he said, Dr. Miron, do you mind if I come to the facial course? I want to go meet Dr. Davies. And we started running this course every 4 months, okay, because it's our most popular course, and it grew every single time we did it. The next time there was 40 people, the next time there was 50 people, and what was happening, we do no marketing. what was happening was a doctor like yourself took the course. You're making an extra $200,000 now. You're telling your buddy, hey, you got to go take Dr. Miron's facial aesthetics course because you can add a lot of extra income by offering these types of services. So the course now, like last November,
Wow.
we had 300 people attend this course. And we have one coming up in April. We already have over 200 people. I expect there'll be 250 people there. And so it's grown, exponentially because of the fact that people are making a lot of extra money, and it's fun, right? When you go to your staff, like a lot of people just do these services on a Friday because it's a lot of fun. And so, yeah, it was, and I did the same thing. Even Perio, I said, okay, Dr. Canner, after the course said, you need to start doing these. I said, no problem. We started doing them Fridays in the office, and I just kept getting busier and busier doing these treatments because let's face it, more people want to do facial aesthetics, the patients, versus, a connective tissue graft, right? And so, it grew quite naturally, organically in the practice. And to this
Wow.
day, like I said, it's our most popular
Yeah,
course.
it's amazing. It's
So-
I'm looking it up right now. April 24th. You might see me there, to be honest.
Sounds fantastic.
Yeah,
Sounds
and the reason